Hi everyone, welcome to our USMLE prep series. Today we are joined by one of our new USMLE counselors, Dr. DeJuan Crinchlow. How are you doing today?
I'm doing wonderful. How about yourself?
I'm doing great. Did I mispronounce your name?
No, it's okay. You did great.
Thanks, I try. Sorry. So how are you doing today?
I am doing wonderful this beautiful sunny day in Chicago.
Loving the almost 90 degrees outside, is it?
It's hot. It's hot. I'm not gonna lie, it's hot.
That's why you're wearing the sweater.
I'm inside in air conditioning, so it's wonderful.
There you go. Okay, so I don't know if everybody has seen our last USMLE question that we did last week, but we're going to toss it up on the screen and start our little presentation.
So, hi, my name is DeJuan Crinchlow. She already introduced me, but
Let's do it again.
tripped a little bit, It's fine. The other USMLE counselors, Dr. Aksa Chowdhury and Dr. Russell Heckburn. Dr. Heckburn actually did it last week. If you are interested in getting USMLE counseling, you can email the bottom email and one of the three of us will get back to you. So the question this week is as follows. A 43-year-old woman comes to the emergency department with complaints of right flank pain for the past hour that has been progressively worsening. She rates the pain as 8 out of 10, radiating to her lower back, no alleviating or aggravating factors, and she has had an episode of hematuria since the pain began. She has no significant past medical history or past surgical history. She denies any medications or use of tobacco or illicit drugs. Physical examination reveals a patient unable to sit in one position due to the severity of the pain. Abdominal examination reveals no abnormalities. The patient's BMI is 29.5. Urinalysis reveals positive beta human chorionic gonadotropin, microscopic hematuria, and pyuria. Abdominal X-ray demonstrates a 4 millimeter radio-opaque mass at the right proximal ureter. What is the most probable diagnosis in this patient? A. Pyelonephritis, B. Nephrolithiasis, C. Polycystic kidney disease, D. Hydronephrosis, or E. Nephroblastoma.
Also, if you guys want to comment in the section below with whatever you think your choice is, or if you have any comments or questions you'd like to ask, please below and we'll be sure to answer this. Alex Trebek would be proud.
R.I.P.
Great guy.
He was. He was a stellar host. Who hosts Jeopardy now?
I think it's like a hodgepodge of like all the past people who've done it, and like the past winners, or if they had a long run, they'll do it. Some celebrities, yeah. So Mason says he answered B for his question. Thank you for participating, Mason.
Worst case scenario, you're wrong and you learn something. That's the worst thing that can happen.
Yeah.
You afraid to take a guess, shoot your shot, flex a lot?
Okay. You want to head over to the next slide?
Yep.
Okay.
So the options we have here, so pyelonephritis, infection of the kidney. Nephrolithiasis is the proper medical term for kidney stones. Polycystic kidney disease is pretty aptly named. So you have a kidney with numerous cysts that ends up destroying the parenchyma. Hydronephrosis, distension of the renal pelvis and or calyces, fancy way to say your kidneys are swollen. And nephroblastoma, also known as Wilms tumor, is a childhood cancer of the kidney containing embryonic glomerular structures. So give people a second to change their answer or stick with it. All right. So the correct answer, as Mason said, is nephrolithiasis. So this patient has kidney stones. So we'll start with going through the other options as to why they were wrong, and then we'll talk a little bit more in depth about kidney stones as related to this patient and other patients you could potentially get in real life or in questions. So choice A, pyelonephritis, they will usually present with fever, chills, malaise, nausea and vomiting, pain with urination, and flank pain for whichever kidney is infected, and CVA tenderness on physical exam. So that test, the examiner puts their hand on the back and they will just hit the back at the costovertebral angle. And if they have that tenderness, that's kind of a good sign of pyelonephritis. It can be caused by kidney stones, but this patient doesn't have the fever, the chills, nausea, vomiting, and all the other signs and symptoms associated with pyelonephritis. Another clue they often will give you in exam questions is that the patient had a recent UTI that was untreated, and then the infection will actually climb up your urinary tract through the bladder, through the ureters, up into the kidney, and that's where you get your pyelonephritis. So lacking all of that, probably not. Polycystic kidney disease is a familial disease, which is either autosomal dominant if it presents in adulthood or autosomal recessive if it is presenting in children. And these people will come to the hospital with abdominal and flank pain, blood in the urine, and a possible palpable mass on physical exam of the abdomen if the cysts are very large. The ultrasound findings would show a large kidney with multiple cysts. So here all we saw was the 4 millimeter radio-opaque stone in the proximal right ureter. There was no mention of any cysts or anything, and no family medical history of similar things. So can rule that one out. Hydronephrosis, swelling of the kidneys in the urine, with urine above the blockage. So if you think of your urinary tract is a constant flow of urine from kidney to ureter to bladder through urethra out of the body. If you block any point of that, like a dam, it'll back up before. So if the kidney stone were to block as it enters the bladder, your ureter and your kidney would swell up. This patient doesn't have any of the signs or symptoms on ultrasound showing that distension of the renal calyces and pelvis, but they can present similarly. So, look for the imaging finding to kind of differentiate between the two. And our last choice, nephroblastoma. Like I said, it's a childhood kidney cancer. So most common prevalence is ages 2 to 5 years old. It can be sporadic. It can also be part of a syndrome like Wagner syndrome, so Wilms tumor, and iridia, GU, so genital urinary malformations, and then a range of developmental delays. Beckwith-Wiedemann syndrome, which will present with Wilms tumor, macroglossia, organomegaly, and hemihyperplasia. So half of your body will be overdeveloped, and you'll have organ swelling as well. And Dennis-Draft syndrome, which is Wilms tumor, diffuse mesangial sclerosis. So they'll have a nephrotic syndrome early on in their life. And then they'll also have dysgenesis of the gonads. So their testes or ovaries will not form properly. But for nephroblastoma, as far as the actual kidney is concerned, usually they're asymptomatic, or the child will have an increasing abdominal girth and parents will kind of bring them in for that. But again, it's a child. Here we had a 43-year-old woman, so highly unlikely that that is the answer. So our patient has a kidney stone. Kidneys make stones, and they throw it down to the bladder. And then once it's in the bladder, you pee it out. So kidney stones can be made of different materials. We'll go through that in the next couple of slides. But the important thing to note on kidney stones is the pain is caused by the moving of these stones. So these stones end up being sharp, and as they move through the urinary tract, it's a hollow tract, it's going to scrape and bump up against the sides and cause little cuts, which will cause the pain to the person and will also cause little microbleeds that you can see in the urine, either visibly or if not visibly on urinalysis, you'll see microscopic hematuria. So the common presentation is they have colicky pain. So all that means is they go through periods of having extreme pain, and then they have a period where they feel absolutely nothing. They feel completely normal, back to the basics, right? But when they have those pain come on, they're unable to find a position to rest uncomfortably. So you'll see these people often like tossing and turning, sweating, just visibly in distress due to the pain. That's a good sign both in the real world and also in the questions that kidney stone is most likely what's going on. The blood in the urine, as I said, and pain in the flank, as well as tenderness in that kidney on physical exam. We kind of talked a little bit about these, but kidney stones can obstruct the outflow of the urine, which can lead to either swelling of the kidney, hydronephrosis, or it can act as a nidus or point of infection in your kidney, which can lead to pyelonephritis and also can lead to dysfunction in the kidney with the kidney stone kind of rubbing up against stuff, damaging things, and especially if there's backup of fluid, you can have that acute kidney injury. So a rise in your creatinine and a acute lowering of your glomerular filtration rate. So we have 5 big types of kidney stones that are commonly seen. The first one and the most common is the calcium oxalate stone. So this will precipitate in a state of hypocitraturia, which leads to an acidic urine. So a few times you'll see this. If somebody is drinking ethylene glycol, which is just antifreeze, so a lot of times, especially in questions, you'll see like a homeless person who didn't have a lot of money and was trying to get drunk. So they drink antifreeze, and then they come in with these kidney stones along with a multitude of other potential issues. Vitamin C overuse. So everybody always wants to pop vitamin C pills or chew the little tablets when they think they're getting sick, or they'll just do it daily to prevent getting sick. But if you take it too many times or too often, you actually can give yourself these calcium oxalate stones. Hypocitraturia, of course, as I just said, and malabsorption syndromes like Crohn's or short bowel syndrome just leads to a decreased reabsorption of citrate, which then you have less citrate in the urine. Hypocitraturia leads to your calcium oxalate stones. Calcium phosphate stones, not as common, but they usually would precipitate in an alkaline urine environment. So our second most common type of stone, the Struvite stone, is made of ammonium, magnesium, and phosphate. So these ones commonly will get stuck in your renal, pelvis, and calyces. So these will be the stones that are big, large, and occupy a lot of the empty space in your kidney. It's usually caused by an infection of the urinary tract by urease positive bugs. So bugs like Klebsiella, Proteus mirabilis, and Staphylococcus saprophyticus. With urease, they will hydrolyze urea and make ammonia, which leads to your urine becoming more alkaline. and then these stones kind of precipitate out in those environments. The next, so third most common stone being uric acid. So as it's an acid, it's associated with acidic urine, decreased urine volume, and arid climates. So a lot of times they'll give you somebody from like Arizona who went on a run and now is having similar pains kind of thing. The other one they usually want to get you to understand is if somebody's in a state of hyperuricemia, so they have a lot of excess uric acid going around in their blood. So gout is a disease that is associated with hyperuricemia, and then also diseases that have a high cell turnover. So like leukemia, you have a lot of destruction of white blood cells. So they're constantly spilling over all of their intracellular components, such as potassium, uric acid, etc. So they're in this state of hyperuricemia, and they are at an increased risk of these uric acid stones. The last one is cystine stones. So it's actually a familial type of stone that's autosomal recessive. It begins in early childhood. So your cysteine, ornithine, lysine, arginine transporter and the proximal convoluted tubule of the kidney loses its function. So you can't take those four things out of the urine to reabsorb back into your bloodstream. And cysteine is actually very poorly soluble in water. So if you can't pull it out of the urine in the urinary tract, then it's going to precipitate out into these stones. This one has its own little diagnostic test, the sodium cyanide nitroprusside test. I would recommend looking that up if you would like on your own time. Pretty cool thing, in my opinion. Maybe not everyone else's, but you know, I'm a nerd. So here I just wanted to kind of talk about the actual identification of the stones. So of note, the only way to actually identify these stones is actually having the patient pee into a strainer until they find the stone. So stones are usually of millimeter or less, like millimeters. So about 5-ish millimeters is usually when you start to worry about the stone being too big to pass and possible lithotripsy to break up the stone and have them pass it on their own. So very tiny, easily missed if you have suspected kidney stones and you want to actually see what the stone is made of, having the patients pee into a strainer. So as far as diagnostic tests, usually imaging is used to see where the stone is, especially and also kind of to measure to see about that size. So most of them are radio opaque, which means they will show up white on X-ray or CT. Of note, the uric acid stone is radiolucent on X-ray, so easily missed if you're just doing like your KUB, kidney, ureter, bladder X-ray. But if you do a CT, it is visible. All the other ones are pretty much radio opaque. You should see them every time. So as far as questions go, under microscopy, they will either give you a picture or they will describe what the actual stone looks like. So I'll briefly talk about it here, and then we actually have pictures of them on the next slide. So the calcium oxalate stone is going to be an envelope or dumbbell shaped. I still don't really see the dumbbell shape. The envelope makes a lot much more sense to me, but that's what they say, so we're gonna say it. For all kidney stones, the number one treatment is you want to encourage your patients to increase their fluid intake, but each one has a little more specific of what you can do on top of that. So calcium oxalate stones, you can give thiazides, which will pull calcium out of your urine, so you have less likelihood of calcium forming into stones. Since we said it's one that precipitates in hypocitrate urea, you can actually give citrate, which your body will be in excess, so it'll pee more out, so you'll have more citrate in your urine, and then a low sodium diet as well. Calcium phosphate will be wedge-shaped prism. It pretty much same treatment as the calcium oxalate stones. Struvite stones, so these ones will look like a coffin lid under microscopy. And if you don't know what a coffin lid looks like, I would recommend looking that up because it's an interesting shape, I guess. The treatment for these ones, again, fluid. As we said, these are caused by those urease positive bugs. So your treatment will be antibiotics targeted at eliminating the underlying infection. And like I said, these ones generally take up the inner parts of the kidney. So sometimes these have to be surgically removed, especially if they're too large for lithotripsy. Like you can't just break them up that way. Then you have to actually go in and surgically remove the stone. Uric acid will be rhomboid-shaped or rosettes. The treatment for that one is to alkalinize your urine. So we said those ones precipitate in acidic urine. So if you alkalinize, that'll kind of help these not precipitate as much. And then allopurinol will also help with preventing your body from making more uric acid. The last one, cystine, my favorite shape, the hexagon. So if you see these, it's just like a gimme. Yeah, just think about hexagonal shapes. There's a bunch of things out there that are shaped like hexagon. So these ones, so these are the familial ones that happen in the children. So you'd want to have low sodium diet, alkalinize the urine, and then push a lot of fluids for these ones. So as far as the actual shapes go, on our top left, we have the calcium oxalate, the little envelope. So it just looks like a little sealed envelope that you're just gonna go take to your local post office. The second one, so top middle, we have our wedge-shaped prism. That is our calcium phosphate stone. I've never seen this one as far as questions go, but that's not to say they can't ask it. So, just be familiar with it at least. The third one, we have our Struvite stones. So we see our coffin lid. So if you look at it, you have that rectangular shape with that central little line. Kind of just looks like it wants to come out at us or it's going away. It's just kind of like a coffin lid. Our fourth one, so bottom row on the left, we see our rhomboid-shaped uric acid stones with some other gunk in there, but of note, the rhomboids, each of those is the little uric acid stone. And then last but not least, our bottom right, we see our cystine stones with the nice, beautiful hexagonal shape that can't be mistaken for anything else. So that's pretty much top to bottom the importance of kidney stones and most of what you would need to get through any question related to kidney stones and other related pathologies, complications, treatments, how to diagnose based off microscopy or symptoms, etc. So we'll leave you with a joke. So I'm sorry, kids, but last night your father passed. Difficult day for the kidney stone family.
Good but for a nice day for the person who passed it.
Yeah, the person who passed it's got to be on cloud 9 being done with that.
Well, thank you so much for going over last week's question, breaking it down a little bit for us. And, it was really interesting looking at all the different types of kidney stones and identifying the different shapes that go with them as well. So thank you so much for joining us today. And yeah, we'll be back next Thursday on social media with a question. And then that following Thursday, we will have our third USMLE counselor to be joining us and breaking it all down for us.
All right. Thanks for having me.